by Prabhakar and Sadanand Shetty. Over to you, Prabhakar, please.
Thank you so much, sir. It's always a pleasure sharing a stage or a screen with you. And when you give a topic, it's always a little challenging, and I learn a lot. When I give a talk, I learn a lot. So that I think is the biggest advantage of a speaker. So first, let me thank Dr. Muruganathan and Dr. Sadanand Shetty, who's, I can just tell you simple words, he's a great man in several terms. So I think it's nice to have him as a moderator today. And Dr. Sangram Biddar, I met during the Epicon also, Lycon, and welcome, sir. So without wasting much time, let me go into my talk. I shall be occupying you over the next about, let's say about 30 to 40 minutes on just one aspect. I'm just going to focus on the systemic hypertension in adults, the WHO statement, which came in 2021. Now, it's a very interesting statement, and the point that I really want to tell you first is very important, which is that this guideline or this guidance is basically meant for chronic management of hypertension in primary care. It's not an advanced statement. It's a chronic hypertension management in primary care, and it overrides the previous modules. So it replaces the HEARTS technical package and the WHO PEN package, which were in vogue before. So this is a new document, and this is what is going to be followed. The prevalence of hypertension, Dr. Muruganathan sir had already said it. 14 seems to be the lucky number for hypertension. 1.4 billion people, are having hypertension worldwide, but of which only 14% have the blood pressure under control. We are looking at global statistics. When this is so bad and so abysmally low, I think the WHO is very correct in trying to simplify management at the primary care level, because not everybody comes to a consultant, not everybody comes to a specialist. So how do they formulate? They had a very, very nice protocol. They had a framework on treatment of hypertension. They asked several questions and gave answers to it with scientific evidence. And the first question they asked was, at what level should pharmacological therapy be initiated? Are lab tests required? Do you have to risk assess these patients? Monotherapy, no therapy, monotherapy, combination therapy, which is the best? Single pill or a free combination? Post-treatment, once you start treatment, so far you're looking at treatment, what is going to be a target for blood pressure? And ultimately, when do you reassess a patient? And should a physician only be involved, or a pharmacist or a pharmacologist can be involved in this treatment? So basically, when they look at it, they've looked at two results, the intermediate outcomes and the final outcomes, which is we call the hard endpoints: all-cause mortality, cardiovascular mortality, myocardial infarction, coronary artery disease, stroke, and heart failure. In between, there is also a small component of adverse effects, which is also taken into consideration in these group of patients. Now, before they went into the data, there's not much of discussion, but they have clearly made a mention that non-pharmacological approach is very important and part and parcel of hypertension, which we very often neglect. Now, remember all these points, each one of them contributes to reduction of blood pressure. Reduction in salt intake, just avoid excess salt, bring down to about 5 grams. Eat plenty of fruits and vegetables. Be physically active, about 40 minutes most days of the week. Avoid tobacco. Reduce alcohol consumption, and limiting intake of foods rich in saturated fats, eliminating trans fats. Very simple. You can tell this to your patient in about half a minute. It took half a minute for me to read the slide. So I think if you're just going to give these principles of diet, it is going to be fairly important for the patient. This will bring down the blood pressure by about 5 to 10 millimeters consistently, and that's going to be very, very important. Now we'll go through the questionnaire and see how this document was framed. At what blood pressure level should pharmacological therapy be initiated? Now, why does this assume important? Because there is a big diff between the American and the European guidelines. Across the Atlantic, the Americans say 130/80 is diagnosed with hypertension, while the Europeans still stick to 140/90. The WHO did its own analysis, did beautifully, and looked at the baseline systolic blood pressure, drug treatment versus no treatment. What is the amount of relative risk reduction? Now, first, let us look at all-cause mortality. Now, the dark blue bar, which is here, is the blood pressure, which is 140 to 149 at initiation, more than 140. The orange one is 120 to 140, and the light blue one is 120 to 130. The green is 130 to 140. Consistently, if the blood pressure is more than 140, there is benefit in all-cause mortality, cardiovascular mortality, myocardial infarction, not much of data, but still there is going to be reduction in the stroke and heart failure also. What we are interested in is 120 to 130 and 130 to 140. Look at the difference in mortality, all-cause mortality, -2 and -3%. Look at the difference in the cardiovascular mortality, -2 and -1%. There is a reduction in stroke when you reduce the blood pressure, but overall, it doesn't seem to be reducing the mortality. There is a reduction in stroke and heart failure, but the benefit is not very, very clear. Now, what happens if your systolic blood pressure on treatment or not treatment, if the patient is having coronary artery disease and diabetes? Now, we are looked in here at all hypertensive patients. Now, when you look at a subset of coronary artery disease and diabetes mellitus patients, you see that patients with a blood pressure of 130 to 140 and more than 140, you compare these two, there is a remarkable improvement in patients who have a blood pressure of 130 to 140. With coronary artery disease, without coronary artery disease, and with coronary artery disease, there is an improvement. Again, if you look at diabetes, if the blood pressure is less than 130, there is a nearly 13% improvement. Now, this amounts for all-cause mortality, cardiovascular mortality, myocardial infarction, stroke, everything shows improvement. Clearly showing that all hypertensives are not the same. The cardiovascular disease patients and the diabetics and the high-risk patients are going to be different. High risk we'll come to a little later. So what is going to be the definition of hypertension in these group of patients? Clearly, WHO recommends a 140/90 as the blood pressure for all persons. Now, if you have an underlying heart disease, we already saw in the previous data that 130 to 139, your patient is going to benefit from treatment. Now, the patients with high cardiovascular disease, diabetes, and chronic kidney disease also benefit. So your definition of hypertension is 140/90 for everybody. If you have coronary artery disease, high risk for cardiovascular disease, diabetes, and chronic kidney disease, you are going to benefit from 130 systolic blood pressure treatment, 130 to 140. Now, this is important for your definition and practically treating treatment, but definitely 140/90 is the important thing. Now, having made a diagnosis, how long can you wait before you start treatment? You don't wait more than 4 weeks. The maximum time permitted is 4 weeks. But should you wait for 4 weeks for all the patients? No. If your blood pressure is more than 160/100, or if you have an end organ damage, like let's say a left ventricular hypertrophy by the echocardiography, you don't have to wait even the 4 weeks. Straight away, you can start treatment. Initiation of treatment without delay is mandatory in these group of patients. Now, you must also understand that they did a specific model called the cost-over model study for low and middle income countries, and they found out that the best by cost-effective treatment was when you start treating patients more than 140/90. The SPRINT trial contested this. They also went ahead and analyzed this data, and even the SPRINT trial's cost-effective analysis showed it is not a cost-saving analysis, and you have to maintain this low blood pressure consistently for more than 5 years to show these beneficial effects, which is not really easily possible. 5 years consistently low blood pressure is not going to be that easy. So having looked at this, once you've made a diagnosis of hypertension, what are the tests that you're going to order? We don't start medication straight away for hypertension. So what do? You generally ask for some laboratory tests. What lab tests are you going to ask for in these group of patients? Should you do it at all? Now, when you want to do these patients, the first thing you must understand, your lab tests should not delay treatment. That is very important. And what are the tests recommended? Very simple tests. One set of investigations like serum creatinine, electrolytes, and a urine examination for the kidney function, a lipid panel, either blood glucose or HbA1c, and a simple electrocardiogram. So these tests are useful. Now, is it always useful? It is beneficial clearly in certain specific conditions, which I'll come to in the next slide. But there are some caveats and problems also. Sometimes you end up with incidental findings, and that might delay in starting in treatment. And don't wait for these results, especially if your blood pressure is more than 160/100 or you find left ventricular hypertrophy. So be careful. Don't let it delay your treatment is very, very important. Now, the condition specifically where this is important and useful is diagnosing secondary hypertension. Though the prevalence is only about 5 to 10% of all hypertensives, if you look at patients who have multiple risk factors or comorbidities, the prevalence goes up from 23, 24, and 39%. Suppose your patient is having multiple risk factors like diabetes, dyslipidemia, smoking, and other factors, the incidence of secondary hypertension is actually on the higher side. So you have to be careful. And it also helps you to guide what is going to be your kind of treatment. Like suppose if you're a diabetic, you're going to benefit from RAS inhibition. If you have hyponatremia, your basic electrolytes show that the sodium is low, you're not going to use diuretics. If your potassium is low, you are looking at probably a secondary hypertension. Second thing is these patients are definitely going to benefit from RAS inhibition and probably the MRAs or the spironolactone as you look at. So lab results definitely have a clear benefit. And you also look at hyperkalemia. If you have hyperkalemia, you're not going to give the RAS inhibition. You're going to be looking at specific causes. So laboratory investigations are beneficial. So the recommendation is You can do those set of investigations for the kidney, the sugar, the lipids, and the ECG. And if you're looking at this, definitely treatment should not be delayed. And if you don't have these investigations, now mind you, this document is meant for primary care physician. Now, if there is a physician sitting in a village without a lab, he doesn't have to wait. Which is the safest drug to start? The safest is a long-acting calcium channel blocker, dihydropiridine calcium channel blocker like amlodipine. So this is going to be the drug of choice in a primary care setting when you don't have investigations. What I call as the general practitioner's treatment of choice is going to be a calcium channel blocker. Now, once you have done this, the common parlance nowadays is to look at risk assessment. What is the risk of developing a cardiovascular disease? We keep asking that again and again. Now, should you do this for everybody? It's very, very simple. Once you have diagnosed 140/90, you fall into the high risk category. No further risk stratification is going to be absolutely essential. But if you're in the 130 to 139, you calculate the risk score. The risk scoring system, the best one for India seems to be the JBS3. If you fall into the high risk category, then a 130/139. Having said that, you must also realize that those patients with CKD, those with diabetes, already come into the 130/139 bracket for treatment. So the risk stratification has some benefits, especially in those patients where you think they will benefit from these kind of treatments. So far we have seen that 140/90 is the blood pressure for treatment, 130 to 139 for certain specific group like heart disease. Do not delay treatment for the lab investigations. The risk stratification needed at some point, especially if it's going to be 130/90. Next, we are going to look at, once you've made the diagnosis, how do you treat these patients? Monotherapy or lifestyle modification? Or within monotherapy, which is going to be the best monotherapy to do? When you look at these, we are spoiled for choice. When it comes to drugs, you have a whole lot of these drugs available. The ACE inhibitors, ARBs, diuretics, beta blockers, calcium, alpha blockers, beta blockers, MRAs, the clonidine, moxonidine, nowadays minoxidil, alpha methyldopa is not in the market. So all these drugs are available. So how do you choose these drugs? I keep telling this very simple. Basically, you go to a doctor, any doctor keeps juggling with drugs. Each doctor has got his own choice of juggling. He judges different drugs differently. And patients keep jumping from one doctor to another when they realize that the BP is not getting controlled. But mind you, it can sometimes be dangerous playing with fire because of side effects also. Ultimately, hypertension treatment, what I believe in clinical practice is something like this. Everything keeps happening fine. Nothing happens till there is a complication or somebody drops the baton, but it just keeps going on. Now let's come back to subject and look at what we are looking at. Now, basic class of drugs are going to be the thiazide diuretics, the low dose or the high dose thiazides, the ACE inhibitors, the calcium channel blockers, beta blockers, and the ARBs. Now look at 2 points here, the mortality reduction or the MACE reduction. The green one is the ACE inhibitors. They score over all other therapies, both in terms of mortality reduction and MACE reduction. When it comes to mortality reduction, the next spec seems to be the ARB. So basically the RAS inhibitors seem to be the best drugs. What are the closely competing drugs? The thiazides seem to be fairly pretty well. The green ones are the calcium channel blockers. They are good. Look at beta blockers. They don't have much of a benefit in terms of mortality reduction, and there's not much of benefit in terms of MACE reduction also in hypertension without any comorbidities. So mind you, this is the reason why we keep saying the RAS inhibitors are very important in treatment of hypertension. Now, the WHO came up with a simple protocol for management in clinical practice. Now, this is just an example. Don't take it as Godspell, because this is not the ultimate treatment. You can replace the drugs. Now, the basic concept of treatment in this group is a simple algorithm. Start with a simple drug like amlodipine 5 milligram. 4 weeks, you can wait. If it doesn't, step it up to amlodipine 10 milligram. If it doesn't, another 4 weeks, add telmisartan 40. If it doesn't, make telmisartan 80 in addition to the 10 milligram of amlodipine. If it doesn't, 12.5 milligrams of hydrochlorothiazide or chlorothalidone, then double it. WHO clearly says at this point, the patient should go out of the primary care. So that is the simple algorithm they've set. Now, why do they keep talking about the calcium channel blockers? Now, look at this data. This is analysis from the WHO annex. They gave a separate appendix and gave a beautiful analysis on Asian patients taking calcium channel blockers versus non-calcium channel blockers. Look at the hazard ratio for cardiovascular mortality, 1.1, MACE events, 1.02, clearly showing that calcium channel blockers versus all other antihypertensives, calcium channel blockers are very good, and you can start using them as first-line therapy in most of these patients. So recommendation on the first-line therapy, clearly, it's going to be calcium channel blockers if you don't have investigation, but otherwise, look at the results. ACE inhibitor and the ARB seem to be better. You can start the diuretic. So it can be any one of these 3 agents that is going to be beneficial. But you must also remember there are some certain specific indications, like what we call as horses for courses indications. Like if you have an elderly gentleman who's more than 65, or somebody who's an African American descent, their diuretics and calcium channel blockers are superior. We'll not go into the data for this. Beta blockers in ischemic heart disease. Now, is it only ischemic heart disease? Because in India, beta blockers are extensively used. I give a good name for that. I call it the happy indication for beta blockers. What is happy indication? Beta blockers are specifically indicators in heart failure, atrial fibrillation, angina pectoris, post-myocardial infarction, and a young woman planning pregnancy. So happy indication is somewhere beta blockers are going to be beneficial. ACE inhibitors and ARBs are going to be the important drugs for patients with proteinuria, diabetes, heart failure, and kidney disease. So we have clear indications apart from the general hypertension. Clear specific indications also have to be borne in mind when you start treating these group of patients. So far we have seen all these monotherapies. But what about these combination therapies? Because nowadays we keep talking about 2 drugs, single pill combination, 3 drug, single pill combination, all those things. Now, what are all these things? Now, basically, you must also understand there are 3 types in which you can increase the antihypertensive therapy. What we saw was the step care approach, where you start one drug, go to the maximum drug dose, and then step it up with the next drug. Now, this is this conventional step care approach. There is also something called the sequential monotherapy. You start one drug like telmisartan 40, add the next drug, then add the third drug. This is called sequential monotherapy. Then there is a new concept, which is the low dose combination therapy, wherein probably use a 6.25 milligram of chlorthalidone with telmisartan, or a 5 milligram amlodipine with telmisartan 40 milligram. I'm just using prototype drugs. It can be any other drug also. So there are 3 kinds of therapies, and which of the 3 is better? Is there any head-to-head trial? Is there a data? Yes, there is a data. There is something called a strata analysis, where they just did about 200 patients each of these group of patients, and they found out that the patients who achieved target blood pressure was best if you initiate therapy with a low dose combination. Next best is sequential monotherapy, and finally the step care approach. So what we should be probably looking at a low dose combination therapy. You must also look at literature and realize that most individuals are going to require more than 2 drugs for the control of blood pressure. And when you combine 2 drugs, the efficacy is much better than individual drugs, and the adherence and persistence are definitely much better. The WHO also makes a very, very interesting statement, which I think all of you should understand. This is the amount of BP reduction is more important than the choice of antihypertensive therapy. There is an importance difference between the choice, but ultimately what is most important is that the amount of blood pressure reduction is absolutely essential. So when you use a combination therapy, non-adherence rate is highest when you use 3 drugs, 40%. But if you use a single drug, single pill, the non-adherence rate is just 10%. Now this works for all chronic therapies. And when you use a single drug like a thiazide or a beta blocker, ACE inhibitor, or a calcium antagonist, the blue is the amount of BP reduction, systolic BP reduction given alone. But if you combine with other drugs, nearly doubling of the effect happens in most of these drugs, clearly showing that the benefits are going to be enormous. And whenever the blood pressure is more than 20 by 10 millimeters of mercury, it is beneficial to start a combination therapy. So combination single pill therapy we have seen has 2 significant benefits. One is the blood pressure reduction is much superior. Side effects are much less because they can countermand each other. Like for instance, if you combine an ARB and a calcium channel blocker, the edema seems to be coming down. So and if you combine it, the diuretic with that, the amount of hypokalemia also comes down. So all these combinations have their own benefits. We'll not go into that. There's several data to show that the single pill versus no single pill combination, basically giving the drug separately, the combination pill is much superior because compliance rates have been much better. So we have seen 3 major therapies: the thiazide diuretics, ACE inhibitors and ARBs, and long-acting calcium channel blockers. Now, which is going to be a drug of choice? Which is going to be the choice of the combination therapy? There is some data to that effect, and the WHO has analyzed the data and shown that the 2 major combinations are going to be RAS inhibitors, calcium channel blockers, and a RAS inhibitor plus diuretic, of which the major contribution came from the accomplished trial. And when you combine these 2, look at the cardiovascular event rate, 18 fewer for 1,000 patients. Clearly, the combination of the RAS inhibitor and calcium channel blocker was superior to the combination of the diuretic in terms of mortality, cardiovascular events, stroke, and even withdrawal due to adverse effects. So clearly showing that the first best combination is going to be a combination of a calcium channel blocker and an ARB or an ACE inhibitor. So the WHO came up with a second algorithm for a combination therapy and said that the first drug, if you want to use, start a low dose combination like a telmisartan 40 and an amlodipine 5 milligram. Next, you can double it to 80 milligram telmisartan plus 10 milligrams of amlodipine. If it doesn't work, add a chlorthalidone or hydrochlorothiazide 12.5 and then double it up. Now, at this point, WHO clearly says that if you're in a primary care, beyond these drugs, don't push your patients. I'm quoting WHO, but I'll talk about this a little bit later. So WHO said, finally, that those patients with more than 20/10 definitely start a combination therapy. Otherwise, it is generally preferable to use a single pill combination with at least 2 drugs. The compliance is better, adherence is better, the effective blood pressure lowering is fantastic. Both adherence and persistence is going to be better. So what is going to be the target blood pressure? We have started therapy at 140/90 or 130/80. So how low should you bring out blood pressure? Now, if you look at the SPRINT trial, that is the trial that questioned everything and said that bring down the blood pressure quite low. Now, you look at the blood pressure between 120 versus 130 to 139. The all-cause mortality came down by 27%. Cardiovascular mortality came down by 40%. But go down and see what happens here. There is a 20% increase in, not 20%, sorry, 20% increase in persons who are getting adverse events. So the trade-off is that you have more adverse events if you try to aggressively treat these patients. Similarly, if you look at 140/90 to 150/160, 140/90, the benefit seems to be more, adverse effects seem to be much less. So clearly, if you try to go too low in the wrong patients, you will land up with more adverse effects. So what are we looking at? We are looking at SPRINT-like results in patients who are going to be SPRINT-like. So what is the inclusion criteria for SPRINT? Patients age more than 50 with a systolic blood pressure between 130 and 180, increased risk of cardiovascular disease. Either there should be a cardiovascular disease, chronic kidney disease, Framingham score more than 15, or an age more than 75. Now look at all these factors. We have already gone ahead and said that 130 seems to be the good blood pressure to start treatment in most of these patients, like multiple cardiovascular risk factors like diabetes, chronic kidney disease, or high-risk patients. So it more or less corresponds to that. And if you start treating these patients, what is going to be the cost? In US, it seems to be $13,000 more costly. It's quite high. Patients require more visits, more medication. It is much more expensive. And treating the lower targets will reduce the returns progressively in low-risk patients. So don't try to be very aggressive in low-risk patients. It may not really benefit. So what is the recommendation by WHO for the target blood pressure? 140/90 for all patients. Again, if you look at it, it comes similar to where we initiate blood pressure. Those with cardiovascular disease less than 130 systolic, those with diabetes, high-risk CVD, and chronic kidney disease less than 130. So it is more or less where we start. That is going to be the target blood pressure, which seems to be having the most cost-effective treatment. Now we are always wondering how low can we go. There is a recent paper in 2021 which looked at patients who had achieved a systolic blood pressure of 130, and what about the diastolic blood pressure, which is going to be the sweet spot. If your blood pressure goes less than 60, there is a clear U-shaped or a J-curve in terms of primary outcomes, all-cause mortality, non-fatal stroke, non-fatal myocardial infarction, MACE events, cardiovascular death. So your sweet spot, if your systolic blood pressure comes to 130, don't bring your diastolic blood pressure less than 60. That seems to be very, very important in these group of patients. And once you've treated these patients, how often should you follow up these patients? Now, if you start a drug or if you change the drug, you have to recheck the patient 1 month later. And once you've treated these patients 1 month later, you must also get to the control. Once you have achieved control, ask them to come back every 3 to 6 months. If not, they are just non-compliant, they just forget the drug. It's very, very important. I forgot one important point here. Let me come back here. Now, if you start treating these patients with ACE inhibitors or ARB, you must monitor the renal parameters and potassium, which is there in the side grips. I forgot just before you leave out of this. Remember, you have to be monitoring at least once after 1 week once you start these therapies for these patients. So we have seen the J-curve happening. We've seen the follow-up of these patients. Now, what happens if you delay treatment? Delaying treatment or intensification of treatment clearly leads to increased cardiovascular death and mortality. Who does this? The doctor inertia. The doctors should learn to treat these patients. Now, if you start BP treatment, if you delay treatment by more than 1.4 months, 1.4, about 1.5 months, if you don't initiate treatment, the MACE event rate is 1.12, 12% increase in MACE rates. Suppose your blood pressure is on treatment and you don't follow them up for at least a period of close to 3 months, about 2.7 months, your MACE event rate goes up by 18%. So clearly, it is not only treatment of hypertension, your initiation of treatment and follow-up also leads to problem. Now, if your patient doesn't get control, now I'll go off the WHO guidelines for those people who are sitting and who want to learn how to treat beyond the 3 drugs. This is basically from the NICE guideline, which is also endorsed in 2020. Once you have taken all three drugs, the RAS inhibition, the calcium channel blocker, and the diuretic, the next step is to look at serum potassium. Look at serum potassium less than 4.5, more than 4.5. If your potassium is less than 4.5, you add an MRA like spironolactone, rapamycin. If your potassium is more than 4.5, don't give these drugs because the incidence of hyperkalemia is higher. If it's more than 4.5, look at the heart rate. If your heart rate is more than 70, give a beta blocker. Less than 70, alpha blocker. By this time, most of your hypertensions are controlled. So we're looking at nearly 5 drugs here, and you should have a reasonable control with this group of patients. Now, recommendation for non-physician professionals, there is a big case for pharmacists treating these group of patients. I don't know how applicable it is to India, but there is also a reasonable result, and the results are pretty good if the pharmacists treat. In fact, the barber study, if you remember, the pharmacists in the barber shop among Black community had a much better results than the hospitals. So there is a real entity there, but you have to train them, give a clear protocol, and know how to treat these patients. So basically, coming back to the first slide that I put in, 1.4 billion people have hypertension, but the control is 14%. And why? Why is there so much of problem? Basically, because of clinical inertia. The 3 inertias: the physician factors, the patient factors, and office factors. Several factors. Physician not knowing what he has to treat, he doesn't initiate treatment, doesn't titrate, doesn't identify, doesn't follow up the patient. Patients are not bothered because they're not having enough education to understand their cost of the medication can be a factor, and those patients are not really worried because it doesn't really produce symptoms. It can be a silent killer. The other factors, there are no clinical guidelines that are accepted by national societies. There are a lot of guidelines, but nobody seems to be bothered. And there is data to show that if your initial inertia is not there, 10-year outcome, most of your patients get a good BP control. If there is inertia, most of the patients do not get controlled over 10 years. So if you remove the initial inertia in 1 year, even 1 year, the amount of patients getting control is good. Like if you wait for more than 2 years, the amount of blood patients getting controlled is not so good. There's another very interesting paper, Gillen et al., which showed that there are 2 kinds of inertia. That is going to be what is called as a diagnostic inertia and a therapeutic inertia. It's interesting. Diagnostic inertia is your sister checks the blood pressure, and if the blood pressure is 146/90, she chooses to write 140/90 because it looks like good control. This is diagnostic inertia, which is man-made error. And therapeutic inertia, where the doctor doesn't treat the patient. Now, remind you, diagnostic inertia is seen nearly 32%, and therapeutic inertia is seen in 37%. Is totally avoidable, and your patient is the sufferer, and you have to look at this. Now, there is a mention about pregnancy and hypertension in the WHO guideline. I will just rush through this and just give you an idea. We are not going to discuss much about this. Basically, 10% of maternal deaths are attributable to hypertension. And chronic hypertension in pregnancy, if you are having a diagnosis less than 20 weeks of gestation, and the prevalence is 1.7%. Gestational hypertension is if you have it diagnosed after 20 weeks, and prevalence is 1.2%. The diagnosis is based on 2 blood pressure recordings more than 140/90 at least 6 hours apart. It doesn't have to be on several occasions. 6 hours apart is more than sufficient. And interestingly, the threshold to initiate pharmacological treatment is very high at 160/105 to diagnose, but the initiation of treatment is pretty low. Now, recently, there is a lot of data to say that you can bring down the blood pressure lower to 85 millimeters of mercury, because formerly we said don't bring it down less than 100. This seems to be having some beneficial effects in maternal and fetal risk, which is a very important document, which is also presented in the ACC-AHA recent conference that was held in March 2022. Target organ damage, if it is present, start treating much earlier and don't wait for treatment. Drug treatment, I'm sure all of you are aware of this. The drug that is going to be first is going to be methyl dopa, beta blockers, preferably labetalol, calcium channel blockers, particularly nifedipine. You can use the hydralazine, the direct acting vasodilator. Beta blockers and calcium channel blockers appear to be more effective than methyl dopa actually in reducing later pregnancy. That is important. Thiazide diuretics, you can't initiate them, but the patient is already on that, probably you can leave it. The red flag drugs are the RAS inhibitors, MRA antagonists, spironolactone. There can be some fetal anti-androgen effects, so be a little careful with the MRAs. And beta blocker atenolol has been shown to produce intrauterine fetal growth inhibition. So be a little cautious about these drugs and don't start using these drugs. So finally, to summarize whatever I have said, the blood pressure threshold for initiation of treatment is going to be 140/90. 130 systolic is going to be the blood pressure for patients with cardiovascular disease, high risk for cardiovascular events, diabetes, and chronic kidney disease. Laboratory testings, if possible, but don't delay treatment because of laboratory tests. And if you don't have the test, the drug of choice is going to be a calcium channel blocker. Cardiovascular risk assessment may not be required immediately, but if those patients between 130 and 140 who don't qualify for drug therapy, it may be prudent to look at high risk factors and start treatment. Drug classes to be used as first agent, all three drugs, the RAS inhibitors, the diuretics and the calcium channel blockers, any of these can be used. And if you look at the best drug, that seems to be the RAS inhibitors, and the combination therapy, the best combination seems to be a RAS inhibitor with the calcium channel blocker. That seems to be the best possible combination at this point of time. Antihypertensive therapy with target blood pressure is more or less similar to our initial blood pressure, 140/90 for everybody. For the high risk group that we had already mentioned is going to be 130 systolic. Frequency of reassessment every month till you control, thereafter once in 3 to 6 months. I think with this, I should say thank you to Dr. Muruganathan and all of you for the patient listening. And I will say thank you and come out. Thank you, sir.
Yeah, thank you, Prabhakar, for that excellent, very simple, lucid presentation. I think all our viewers were very happy about your simple presentation. There are a lot of questions in the chat box. Now,